Right, thank you. Dr. Gotkin, this is Dr. Nadeem Rizvi here, and we've got a esteemed panel here, Dr. General Zafar,
Okay.
Dr. Bandesha,
Yes.
Abdul Hakim, Samad Saab, Ali Raza,
Let's see.
Abu Bakr Sheikh Saab, Sarwar Saab. So,
Yes.
can you tell us the case? Hello, can you
we have
hear
good
us?
options here. First, septals have three, maybe the mid 1 meter. It's tortuous, but it's okay. And we have other one, very nice correctors.
Dr.
The
Gotkin,
last
this
one
is
also looks okay.
the
Then we
hall
have very good
A.
option for
Hello.
Yeah.
Right, we've also got on our international visual panel Dr. Fahim Jafri, Dr. Najib Azam, Dr. Afsar Raza, Dr. Imad Shaban, Dr. Hatim.
Maybe I have to have it.
So they are also on the visual
Monitor has to be done.
virtual panel.
And more close to me. Yeah?
I think we are having problem with the audio. We can see the case, so obviously it's
This is for protection, okay, for protection of
contralateral
already,
injection case, so it's probably a CTO.
Okay.
Right, hello.
This is good here. We are almost ready for live case, yes? If they ask, we are ready. So let's have bilateral injection, sorry. Yeah.
So while they can't hear us, any comments from the panel regarding the cases that were shown
What's your name?
previously?
And I like it.
If you had seen the patients
Hisham, and
with the
what's your
provisional
name?
stenting to the left main.
Anjum.
And your name?
Muzaffar is Turkish name. Kurum. And then Anjum.
Anjum.
Yes, please, because flash. No, I mean.
Right. Anyone from the panel regarding 1 stent, 2 stent for distal left main,
So we have
the
to
way they did the case?
careful.
Ali Raza?
So it's a thrombus and we might
I think for the, my go-to usually is one stent
Hello.
always,
Pakistan
provisional
live,
strategy unless and until there is anything different which I found in it. And for left mains, I stick to imaging as well, so I always go for the imaging in the, that's my only left main strategy where I use imaging and decide according to that then.
Yeah, I think we need to realize, Dr. Shaoling, how are you? Can you come up in the front and have a seat on the sofa? We have a few questions for you.
A little bit this way.
The question in Pakistan, 80-90% of the labs don't have IVUS. So if you've got a distal left main, a large left circumflex with some disease and without imaging, I think with the results of the DK crush, how many would feel that that would be a upfront to stent strategy
So I want to add as
without imaging?
So you're right, because even in the bifurcation trials, they only use 12% of the imaging. So imaging, you're very right, it's not compulsory even in it. Even in the bifurcation, all the trials, the consensus documents, the use of imaging wasn't that much actually in it. So again, I think that the provisional strategy always takes advantage on it. But unless and until there is a disease, then obviously a DK crush.
Okay, sorry. I think we may have communication with Dr. Gotkin. Can you hear us in the lab?
Yes.
Yeah, Hashim, I can see Hashim. So it's a multi-hospital case. Can you tell us the case? Someone can tell us what you are doing?
Right. So who will present the case?
Okay. This is a 65-year-old male hypertensive.
Do I have a microphone here?
Yeah, can you hear? Zara zor se bolo.
This is a 65-year-old male hypertensive smoker who presented with a non-ST elevation MY 10 days ago, and previously he had history of non-ST elevation MY 3 years ago. Since then he is on regular medication. This is the first cath which has been done during this admission, and you can see there is a right coronary artery which is totally occluded. And can you show the views, please? The first views, and the left anterior descending artery also has a tight mid stenosis. So I think you can see the screen, and from here on I will give it over to Dr. Umar.
Right. So first of all, thank you very much for having me as live case operator for Pakistan Live Meeting. I am extremely happy to be here really, and I felt that I miss Pakistan a lot. So thank you very much for invitation. So I'd like to introduce my team here, and the second operator, Hashim Mohammed, he's my fellow. He was my fellow. And we have Dr. Kurum, Dr. Anjum, and Muzaffar, Dr. Muzaffar here. Yeah, we have excellent team here. This is the case. Let me show you what we have today as CTO angiogram. Okay, the first image, please. Is this the first one? Okay. So the left system, right. So let's go to first image. From the left injection, please tell him. Okay, this is epicranial. We have spider view. Spider view, yes. In here we have also CX occlusion. I think maybe we should treat this later on if we have any ischemia, that part. But LED has moderate to severe stenosis. Next, please, at the mid part. I think this part also should be taken care of. And we have a nice collateral from first septals. First septals are big septals and has 4 side branches, and almost all of them has connection to RCA, which is very good news. Okay, next. Another view, and next please. So from right injection, you know, we have ipsilateral collateral as well. It's very tortuous, but filling is very nice. So it's not that long. It's not that long CTO, but we might have some ambiguity of the proximal cap. In here, I think I'm seeing, can you see now? Yes, I think I made,
Yes.
I see something that I assume that it's a proximal cap, but I'm not sure. So let's have another view from aerial, and we will do it only on the right, please.
So,
Yeah, from aerial, let's see if we have any proximal cap. Yeah, I think we have something there, but I think we had better to do iris guidance here. What do you think? We have 2 options. One is directly goes to retrograde, which is okay, or since it's not that long lesion, we have a very good chance for antegrade wiring here. If we find good penetration place for proximal cap. So, and secondly,
yes, thank you.
I don't know your comment and suggestion, but according to us, we are ready to use IVUS for guidance to see proximal
because
cap.
of some
if it
issues,
fails, we will go to retrograde.
right? Because of some issues with the audio visual, let me just explain for someone who hasn't heard. So there is a circumflex occlusion. There is an occlusion of the right. The collaterals are both from a large septal as well as isocollaterals from the right coronary artery. And Dr. Gotkin is asking whether he should go antegrade because he can see a proximal cap, or whether they should go retrograde. So let's start with the panel. Dr. Hakim?
So I think, yes, we can talk about the CTO, but when I look at this patient, he has a high syntax score. There is some left main disease, there's an intermediate LA disease, the circ is a CTO, the right is a CTO. So yes, we could try wire escalation or then dissection reentry if we were to go subintimal. But if we do decide doing septal surfing, the LED is going to get really ischemic and the patient could really decompensate. So that is something I would really pay attention to proceeding forward.
I'll forward. Dr. Gotkin, a comment from Dr. Hakim was that if you go retrograde, the LED might get ischemic. That was one of the suggestions. That comment was that if you go retrograde, you might get ischemic because the circ is occluded and there's a large septal and you might have problems. So what they are doing is they are using the IVUS to see whether they can enter, because they can identify the proximal cap and then penetrate it, probably going antegrade first. So I think they've taken your suggestion.
Yes, I fully agree. We have a mild to severe stenosis. I just wire it. I don't think it will cause harm. But if I work through that moderate lesion, I have to stent it for sure, because after crossing with microcatheter, and if microcatheter stays there a long time, we might have a problem. So we have to stent it, even if it is moderate. Yeah, but here I just wire it. If I use septal, big septum, it's proximally to the lesion. So I don't think in this particular case, I don't think I have to treat first mid LAD if I go retrograde. Okay, so okay. But you are right. If I drew this moderate lesion with microcatheter, yes, I had to do it. I insert my wire, any wire here, BMW.
Yes. Dr. Haitham, from
as a setup, we do biradial approach here. 7th branch for left system, 7th branch EBU, and right Judkins, 7th branch right Judkins for the right system. Why we choose right Judkins? We would like to do anchoring when we need it. This is also some people might use here LA1.
Okay, Dr. Godkin, we have some good experts from international on the virtual. I'll ask Dr. Haitham from Kuwait to make a comment on how they would approach this case. Can you have your audio?
Thank you. Yes. Thank you. Yes, I can hear you. I'm from Bahrain, but Kuwait and Bahrain are one in the Gulf. So actually looking at the anatomy, this gentleman came in with a recent non-STEMI, which means that the RCA CTO is probably not the culprit. The culprit is either the mid-LAD lesion, which Dr. Goktekin will tackle on the way out, and presumably the circumflex. Now, I did not see the angio very well to assess the LCX. Now, I'm not a CTO operator, so what I would do personally is I would fix the mid-LAD and then send the case to my colleagues who do CTOs to actually, operate on or try to fix the blocked RCA CTO at a later time. But I think with Dr. Goktekin's expertise, he can probably fix both at the same time, fixing the RCA CTO and then the mid-LAD, which I think is probably the culprit for this man's recent non-STEMI.
Thank you. Thank you. So did you hear that, Dr. Gotkin?
Yes. So, yeah, thank you for nice comment, Haitham. Yeah, and I like to do treat LAD as well, but this is, now we are in the live, and I don't think we have a time to do it because we have limited time. Let's do first, I have a wire there anyway. Let's do first right CTO, and after that we will start left system, LAD.
Okay, so
now I inserted my microcatheter, which is Prosmet microcatheter. I use this as a first time. Let's see how is it. I like to have as a first wire, I like to have Gaia second, okay, because I don't want to choose here hydrophilic wire. We have two side branches. It will be difficult to puncture proximal cap because we have two side branches. My hydrophilic wire can easily go either of them. So let's have Gaia second. And can you see IVUS now? I like to show you proximal cap.
Okay, Omar, so we cannot see the IVUS. Can you put the IVUS on the screen, please?
Please put the camera over here with camera guy.
All right, now please ring down. Now you see IVUS. Am I right? No. Please show them IVUS, please. As a big screen. Ring down, please. Ring down. Yes, thank you very much. And can you see? No. They don't see IOS.
Not
Please
yet, not
bring them
yet.
IOS. IOS has to be in the hole. No, I don't see it. IOS.
Yeah, now we can see it, yeah.
I know, now they see. I see what they see. So now they see it. Yeah, okay. So the camera has to straight. Okay, the screen has to be straight. No, not to me, to camera. More.
Yeah,
More.
that's fine.
All right.
That's good, good.
More. Okay, fine now, okay. So this is side branch. How we know where is the proximal cap? We go to side branch. This is smaller, right? So then we will see it becomes bigger. That's the junction. And when the image became bigger, we should look for the proximal cap. It has to be around it, right? So now I'm the side branch for sure. And I'm pulling my probe a little bit back. And here, you see,
Yeah.
here I'm
At 10.
in the main branch. And at 11 o'clock, I have a proximal cap.
Yeah.
Right? So, and now I have to check with, push a little bit in here. So, here, exactly where should I puncture? If you can, go to LAO, please. LAO view. And then I'd like to have injection to see where is the
Omar,
probe.
can you guide us through the steps of doing a IVUS guided puncture, about the views? Which view do you take and how do you correlate it with the IVUS? Can you just take us through the steps?
Yeah, shooting. Okay. So, all right. So, and here, okay, now my, pull a little bit back, and in here, yeah, exactly. Now I am at the bifurcation, yeah. So the tip, the tip of the probe has eye, so I have to go at the tip and then rotate. When I rotate my wire, I will see on the fluoro. You know, if I go the opposite direction, I have to, torque my wire to go the other side. Let's do it together. Can I have Gaia? Yeah.
So you're using Gaia 2.
Yes. I'm choosing, this wire is maybe 90% of the time is my first wire in any CTO.
So Gaia 2nd is your first wire for these types of CTO. Gaia 2nd.
Yes.
Yeah. Okay.
And I inserted my microcatheter with the BMW, and now you see my tip of micro here.
Yeah.
So I am out now. Okay, let's see IOS. Okay. So try to see my, so you see that
No, we can't see the wire
okay,
yet.
you see
yeah,
my wire?
now we see it, yeah.
It's 11 o'clock, you see it, right?
Yeah,
So
yeah,
I
yeah.
think this is good way, because I'm the plug now. Let's try to go down. Yeah.
So between 10 and 11, you've got the tip of the wire.
So I puncture, let's come back a little bit. Please focus to IOS now. You see, at 11 o'clock, you see my wire, I believe, yeah? It wasn't there. So here, my wire is at 11 o'clock. I can pull it back for you, but I don't want to miss my puncture side. So I push a little bit my micro because I need support, because my wire stops there somehow. So I push my micro more, try to have better support. So I come back a little bit more.
I mean, you do see calcium at the proximal cap, so maybe if this doesn't puncture it, you may want to at least puncture the proximal cap with something heavy duty like a Confianza Pro or an Astato, and then switch over to a Gaia second.
So I penetrated at proximally, but now power of my wire is not good, not enough, sorry. So 340, okay. So what should I do here? I need support. I push more my macro, but this is the end. I cannot, talk please.
So he
What can I
penetrated
do
with the
Scope-
Gaia second, so the penetration was not an issue. The problem is now talkability and getting it through into the distal part.
And so options here, now I see my proximal cap, so I want to remove my IVUS,
Yeah.
and then I'll insert a balloon to anchor it to a short balloon, please. Then I will have better support.
Dr. Shaolang Chen is speaking angiographically.
But now I know where is my proximal cap.
So he's penetrated the proximal cap, removed the IVUS so that he can put in a balloon for further support.
So now I will have better support, and but power of Gaia second may not enough. In that case, I will have Gaia third.
Sorry, Dr. Shaoling, yeah?
Yeah, Shaolang Chen is speaking. Angiographically, I feel large RL valve is the best valve to guide the penetration. Thank you.
Right, okay, thank you.
Sorry, Nadeem, can I have a quick question?
No, it was a comment by Dr. Shaoling. Can you, for the audience, can you say that again? Please, they were asking about the penetration.
Yeah, I feel large RL will be the best valve to
RAO,
penetrate.
yeah, okay. So, the
RAO,
comment
yeah.
from Dr.
The first-
Shaoling was that RAO would be the best view for penetration.
Can I quick question here?
Yes, sure. Dr. Najib
So,
from
yeah,
UK.
my quick question is for better wire support, balloon anchoring is better than the guide liner?
Yes, I mean, in terms of, in my practice, in terms of power of the supporting, anchoring is better than guideliner. Yes, I can tell you that. I have different scenarios, and what I found out at the end, this is, in my practice, gives more support than guideliner itself. Yes, but in CTO, guideliner has other advantages, like if I go retrograde, for example, it's better to have guideliner there, but it's another additional cost. So, I mean, in my country, we always think about the cost as well. If I need to use guide extension, yes, I use it, but if I do this with other cheaper method, I'll do that one.
I think this would be a great opportunity since you have the RV marginal collaterals occluded to do injection from the left and really identify how much of the distal contribution is by the septal collaterals. So if you are to do septal surfing later, because right now on your setup shot you have a mixed contribution from both the right to right and the left to right collaterals.
I think there is now some disruption in the
Not
way
now,
they've got the other wire. So now he's shifted over to a harder wire. I think it's Gaia
Can you have
3.
RAO, please? RAO. Yes. Yeah. This one, this is the good one, yeah. RAO, please. Now I have better support, and
He's gone over to the RAO view. So that's probably...
in this way it has to be straight. After inserting my macro into the CTO, If I could, I would change my wire, but it's not easy all the time. Let's try if I push it. Yeah. I think I am in the black now. I have Gaia, I like to have Gaia third, yes. Can I have LAO, please?
So Omar, you've got an anchor balloon in your other branch? You're using an anchoring balloon for support?
Sorry, say again. This is fluoro balloon for anchoring. Now I have a great support now. I was able to push my micro into the proximal cap with help of this support. So I believe that LA1 itself cannot give this support to me. Either we have to use guide extension or anchoring balloon.
I can see Asad Pathan. Asad, do you mind contributing, coming over as an expert? He does quite a lot of CTOs, and other is one of our premier experts. Asad, can you come on the panel, please?
Omar, quick question. You're changing the wire over microcatheter. You don't do balloon trapping, you just do it with the syringe?
No need. If you don't do injection, no need to do wire change with the syringe. If you do tip injection somehow, yes, we have to do it with the help of, we have to suck air, yes.
Yes, Omar, we've been joined by another friend, Dr. Asad Pathan. He's going to ask you, Asad, how would you tackle this at this stage?
I don't know. Let's see. Yeah, it goes somewhere, but I don't know where is it going. Because I punctured something. It's either wall of the vessel or, let's see, RAO please? Or puncture some calcified part. Let's see.
Yeah, Omar, Asad is here, Asad Pathan, and he'll just make a comment on how they do it at Tabba. He does quite a lot of high volume cases of CTOs. Yes, Asad.
I would have done it exactly how Omar is doing it right now. So antegrade first, and I was guided proximal cap puncture, get the microcatheter in, and escalate if need to, like he's doing exactly. So.
And the wire choice is the same. Start with Gaia.
Yeah.
Okay.
Okay, let's see now. We can give some contrast with the left system as well, or this one. Okay. Both one is better because we also upload some collaterals. All right, left system. I need good injection from left system too, yeah? Left system.
No.
Omar, if we can have a better injection, because you could see the RCA.
Because we have the pressure down, I remove my guiding a little bit back. So, yeah, okay. Injection, please.
Start.
So we know where the wire is.
Okay, proximal part feeling from
RCA.
right, yeah.
Right,
so
laterals.
I pull my guiding a little bit back for left system, okay?
Slightly off.
For security. And please down the balloon to see better distal, yeah. Now I like to have nice injection from the right system. Please.
Okay, ready. You have to engage it a little bit more selective.
Okay, good injection, please.
Okay, that's nice.
All right.
Hey, great.
This looks not bad. Let's see from other view.
Hello, please. See, I would have anxiety doing an antegrade dye injection, especially if you go subintimal and you have your microcatheter.
I think I'm not in the lumen. Okay, injection, please.
Engage the guide, the right one. Okay.
Yeah, that would have been my concern too, doing an antegrade injection in this situation.
But I'm close, yeah?
Yep.
So I want to go a little bit
Close to the
down.
cap.
So is somewhere within the plaque, within the CTO, whether it's subintimal or not, we'll soon discover. It depends on the movement of the tip and how smoothly it goes
That's still free.
forward.
No, I'm not sure.
Oh, yeah, we are not.
Because the wire is not free, I don't think it's in the true lumen.
It's around.
You know, let's see from other view. If I am not in the true lumen, I don't want to waste time here because I can do parallel wire. But let's do retrograde. It could be faster.
Your question, your point
yes,
about dissection getting worse with in CTOs with just a wire inside, unless you ballooned or use some other equipment, usually it will not make that much of a difference. But yes, it could propagate. So antigrade injections are not recommended
I can
usually.
redirect this wire a little bit. I can play another 2-3 minutes.
So he's withdrawing the wire and trying to rewire because... So Omar, you think you are subintimal?
Yes, I think so, yes. Yeah,
okay.
I think so. Because my wire is not free first, and movement I don't like that much. I go a little bit down. Okay, dancing is not bad. I mean, I may not be in the movement, but I am definitely in the architecture. Okay, injection. It looks nice, huh? Hello?
Hello, please.
So maybe I am still in the CTO. That's why my wire is not free.
Dr. Shaoling, is this how you would have approached it?
The 2000.
Certainly, I will try anti-grad approach.
Ready?
So angiographically, I feel there is a sharp angle
Light is going out.
just proximal to the distal cap. So I think we need to use a more stiff wire, like a Congress Pro 16, something like that, with a very, very gentle curve to negotiate the long access of the distal right coronary artery. Now the wire tip is in the fourth lumen. So I think we need to reshape the wire, change it to use a more stiff wire. Thank you.
Right.
I think another option at this stage is he could get the microcatheter into the CTO body and change to maybe a polymer jacket wire, probably a Gladius, or we only have Pilot 200 here. That might allow him to re-enter into the true lumen.
Yeah, Omar, the comment is that some suggestions were to change the wire now that you've penetrated proximally your subintimal and maneuverability, etc., getting it easier, maybe changing the wire.
See, I think this is
changing. Yeah. I mean, if you want to go interluminal, so I think the Gaia is good option. If I choose Gladius, I can do knuckle, okay? But I don't want to do knuckle here because I have a good option from retrograde, and you know.
Omar, I can see another of your friends here, CTO operator, Sohail Aziz. Can you come on the panel, please? Because you do quite a lot of CTOs, and I think in this case, people like you and Asad should be involved.
Yes, you know.
So we have Omar, we have Sohail Aziz also on the panel now, and he'd like to make a comment.
Hi, Omar.
Yeah. There are
so it's nice to see you working. Omar, lots of time at a position where my wire is so close to the lumen, I use a buddy wire. I trap the micro and I pull it back and I put in a second wire through the same micro and buddy wire it. And if you parallel wire, lots of time you go close to it and you can find the true lumen. And you know where to go for. Trying to pull it back, changing its shape may not be very useful. You may not get even this far next time.
All right. So buddy wire means parallel wire, right?
I would want another Gaia as a buddy wire. That might help.
So you mean the parallel wire technique?
Yeah, parallel wiring.
Parallel wire.
And that gives you a lot of support also.
That's an option, yes, for sure. But I have nice collateral option here. Let's see. We have many options.
Yeah, it takes you just 2 minutes to buddy wire and see where it goes.
Like
and many
a comment
times
from Dr. Imad from US, from Italy. He's been quiet. Can you make a comment, Dr. Imad? Shaban? Your audio, you can, yeah.
Yes.
Yeah, what do you think about the case? Would you do it similarly?
Yeah, I would change, at this point, I've changed with another wire and try to get into the lumen with another wire.
You know, taking this wire out and trying another wire, you may not even get this far. And previously just subinterval close to the lumen.
Just to be more straight. And let's do parallel wire. I have a logic here. So let's do parallel wire.
Which wire do you want?
The guy at third. Yeah.
Yeah, he's in a good position.
Yeah, but I'll have to remove this one. So first, I'll have to remove this guiding microcatheter. Okay.
Omar, another advantage I have with parallel and buddy wiring is that, you know, when you get another guy down the proximal cap, you crack the proximal cap also a little more. And so then putting your balloon across becomes easier.
So we do not so technique to remove, be careful.
Yeah, I would not want you to remove this wire. You may not get even this far next time.
So, okay, we like to do, let's try it again. We like to do parallel wire, but we lost
Omar
the
can
wire.
do anything.
Yeah, Sohail, you remember the Japanese guy at AFIC? So the whole panel was going around and telling them, said, yes, yes, so, and kept on doing exactly the opposite of what the panel was saying. So I think it is probably not very wise to advise Omar. So he's taken that wire off. Omar, what are you doing now? What is your plan?
I'll send another wire now. All right. So, no, what I do now, guys, okay, I forget parallel wire because we lost this wire.
Oh, you
While
lost
we
the
do not so, the wire come back, right? So, let's do retrograde approach, okay? It will be faster, believe me now.
So he's shifting to retrograde.
Omar, one thing you could do right now is take an XTA and see if that'll just cross because you've already punctured the cap. And we find that very often it's a 1 gram wire, it'll find its way down. So it's something to keep in mind.
I'll go retrograde.
Omar, it's a tricky case. I don't want to bother you too many questions, but what is your feeling about parallel wiring and buddy wiring? You don't think that's a good idea?
No, definitely good idea. My friend, this is good idea. It's option. There are 3 or 4 good options here. None of them I can't tell, no, it's not good. All of them are good. Parallel wire is definitely a good option. I love it. I do a lot, you know it. But in this case, I believe if I use the retrograde option, it could be faster because right now, I lost my first wire, right? So I have to go again for the first wire. And I have to remove my macro, and I have to insert it again. So
I just felt that before you go retrograde, maybe a quick parallel wiring might be useful.
BMW inside.
Yeah, I think you should try a bit more integrate, considering that it's a N-STEMI case as well, and going integrate will be a bit more. Okay, I would have tried a bit more integrate.
Omar, this is Bashir. Good morning. How are you doing? We might have to actually go to a talk, and we'll come back to you if that is okay.
Yeah, just give me 5 minutes. I'd like to show you how we cross the
okay.
Collateral. Okay? So, can I see on black here, please? See on black.
So 5 minutes.
So I'm just interested in finding out, we're committed to the subintimal space now. How many of you would make a knuckle and use a stingray in this case? Because this lead is a very nice platform to re-enter.
So Hakeem, that's the difference between the Western and the Asian algorithms, that the Western quickly switch over to ADR, where the Asians would continue working with parallel wire and try and, or maybe then go retrograde. But you're right, if your first wire is subintimal, then either you go try and do ADR or go retrograde, or parallel wire is the third option.
See, the issue when using a parallel wire is you really got to expand your subintimal space.
That's very
and
true.
then that precludes using
ADR becomes more
later because the subintimal space is so big. The idea is to create a very dry fillet with either a knuckle with a Fielder XT or use a cross pass. and then take your stingray and re-anchor. Once you do double, triple wire, parallel wire techniques, subintimal space is too big. ADR is out of the question.
You're right.
I think
So
you're losing
parallel
flow in
wire,
the
you shouldn't
LAD.
push it so much that you enlarge your subintimal
You know,
space.
the,
So protecting the subintimal space is very important.
Hakim Saab, the wires have improved so much since the day of knuckling and all, and we don't have crossbow. That's cost like 10, 12 lakh rupees a set. So integrate wires are so improved that we don't see that very often now. Although the algorithm says if it doesn't go, integrate. But now in retrograde is gaining much more polarity. People are more comfortable. So rather than knuckle, they'll go retrograde.
Sir, I think the
recrossing becomes.
In the US multi-center registry, the retrograde registry, they published, there was a 6% complication rate. So you have to keep in mind, this is in the hand of retrograde operators, that retrograde is not a benign option. And you have to look at, and you're very right that we don't have the stingray available or it's prohibitive cost. So, there are pros and cons to everything.
Unless you have a team ready, where your nurse, your wire managers, you have your radiographer who knows how to pan, how to take the pictures, how to check the ACT. The whole team is not geared for CTO. Retrograde is not a great idea at all.
I think if you don't mind, we have to stop. We have to, Omar, I think we have to go to the talk because we are running behind and we have a case lined up in China as well. So we are going to come back to you. We are going to get the talk by Dr. Imad Shaiban from Italy. And he's going to talk about when is the second stent needed in bifurcation PCI and role of imaging and physiology. Dr. Shaiban, thank you very much for being here. You were part of Pakistan Live last year and this year as well, and we really appreciate that. So you can go ahead, please. Can we switch to Dr. Shaiban?